Welcome back, everyone, to the series where we discuss how to ensure physicians get paid for the care they deliver. I'm your host, Marney Reid, and this is podcast number 2 in this series. Now, if you caught our first podcast, we discussed clean claim rates, first pass resolution, and denial categories, which really act as the building blocks of understanding where your rev cycle could be breaking down. Today, we're shifting to something just as critical and honestly, maybe even more eye-opening, and that's talking about reports and metrics that tell you whether your revenue cycle is healthy or whether it appears to just be doing okay. I'm joined again by our 2 incredible guests, Alexandra Stephens from Fellow Health Partners. Lex, welcome back.
Thanks for having me. Happy to be back, everyone.
And of course, Dr. Abigail Campbell from NYU Langone. Abigail, great to see you again.
Hi, guys. Thanks so much for having me.
All right, let's jump right into it. Lex, I want to start with key reports that every office administrator or ASC administrator, and in my mind, surgeon, should be reviewing each month. You specifically called out the charges, payments, and adjustments. You refer to these as CPA and aging accounts receivable, AAR reports. So, can you break those down for us and explain why they're so important?
Absolutely. Your charges, payments, and adjustments report is probably the most important of the 3. While it breaks all 3 down, it's important to see your charges and payments. However, the adjustments show the money you're not collecting, which is important to see. It's the difference between what you build and what you actually receive. But here's the thing. The reason behind the adjustment is what really matters. Not all adjustments are bad. Some are completely expected. For instance, your contractual adjustments. We refer to these in the RCM world as write-offs based on your payer agreements. Your practice agrees to accept a certain rate, the payer pays that rate, and the remaining balance gets written off as a contractual adjustment. That's normal. That's how the system works. But the problem, and this is where it gets really important, are the preventable write-offs. These are the claims that were written off with no payment or minimal payment due to issues that could have been avoided. Some examples of this are timely filing, not eligible of time of service, non-covered, not medically necessary, no authorization. All of these are examples of not contractual. These are preventable losses. And if you're not reviewing these reports on a regular basis, you may have absolutely no idea how much of revenue is quietly disappearing from your practice. And trust me, the payers aren't going to reach out and share this information with you.
Well, that sounds not only overwhelming, but kind of terrifying.
This all sounds very interesting and frankly really complicated. You're so smart, Lex. Can I have a real world example of what a preventable write-off would be like in my universe? I think for most surgeons, including here, we hear write-off and we think that's something that's kind of out of our control, done on the back end. How does this apply in real life as a surgeon?
Great question. And honestly, this happens more often than people realize. Here's an example that we're seeing a lot, especially with the new plans and split plan designs. Let's say you perform a shoulder scope. Everything is done correctly. The operative note is detailed because we all know orthopedic surgeons are very thorough with their documentation. Coding is clean, medical necessity is clear, but the patient comes into the clinic with what they believe is the same insurance. However, the patient didn't realize that their employer rolled out a new plan or split plan, and now their insurance plan is tied to a different network, or it requires a referral when before it didn't. So when your front desk asks, "Hi, has your insurance changed?" the patient honestly says no, because to them, it hasn't. But behind the scenes, everything changed. Now the claim gets submitted the same way it always has, no referral on file, possibly routed to the wrong payer or network, and comes back denied. At that point, the billing team has to figure out what changed, try to obtain a retro referral, which isn't always possible, correct and resubmit the claim, and continue to follow up until the claim is paid. Now, if the retro referral can't be obtained or your office is underwater, and doesn't do everything within the time frame required by the payer, meaning the claim is pushed past the timely filing limits, you have to fully write off that claim. And that is just one of many types of preventable write offs.
That's crazy. Our own insurance within our system changed this year, and every time I go to the doctor, I'm like, "Yeah, same plan, yeah." Terrifying.
Here's another example. A claim first denied for medical records, and on resubmission, denied a second time, now labeled as not medically necessary. What often happens is the billing team receives the medical records request, but instead of reviewing the payer's medical policy and understanding exactly what documentation is needed to support the procedure, they simply send the operative report or a single progress note. The problem is, many of these procedures require much more than that to meet the medical necessity. The payer may be looking for documented conservative treatment, imaging findings, failed therapies, duration of symptoms, prior injections, physician indications, or very specific clinical findings that justify why the procedure was performed. And as all of our surgeons out there know, when a payer decides to add or change a medical necessity requirement, they do not spend a lot of time explaining this to the practices. So, back to the example. When only the opera report is submitted without the supporting clinical picture, the payer views the claim as incomplete documentation and often upholds the denial as not medically necessary. This isn't a reflection on your in house team's effort. In every audit I've conducted, staff are doing their absolute best. They simply can't keep up with the constant stream of change, or they don't know what to submit. Still, this becomes another example of a preventable write off that ultimately costs the practice and the surgeon revenue.
I'm starting to wonder if we should maybe have this podcast sponsored by Losartan.
Oh
Just get
my
like a little
god.
antidepressant out there to everyone and maybe ask them to, take it right before we record.
Yeah, get our blood pressure down. That's so frustrating to hear from the surgeon's standpoint because the surgeon did everything they were supposed to do. The documentation right, was coding was right, and the money still vanished. And not trying to point a finger or blame it on anyone, it's just enlightening and kind of shocking to me how complex this is for us to collect the care that we're just giving straightforward to fix structural pathology for our patients.
Exactly. And that's what makes this so important. In most cases, the surgeon has no idea this is happening and may never know these denials were preventable. Private practice surgeons feel it through the reality that they work harder every year just to make the same or sometimes less income. Bonus structures for many employed surgeons are shifting from the pure RVU model that we all know before to collections based on compensation, which means this isn't just a private practice issue. Employed physicians are feeling the impact too.
Part of me thinks that maybe some payers had hidden microphones in all of the rooms where I ran resident and fellow courses where we talked about the different employment models. And they heard surgeons say, "Well, I'm not even going to worry about billing and coding because I'm just going to be an employed surgeon." And they went, "Aha, okay, shocker." But I have another question. How does a surgeon or an office or agency administrator even know these things are happening if they're not actively looking at the adjustment reports, and if somewhere on that adjustment report an exact account of what was denied for issues like the example you just gave?
That's exactly the point, Marnie. Most practices either aren't reviewing these reports or they're reviewing them without context. They see a total adjustment number and think, okay, that looks about right, without ever digging into what's actually driving it. To really understand the report in order to fix the preventable denials, the adjustments need to be categorized. A good adjustment report clearly shows contractual versus non contractual write offs. If there is a spike in non contractual write offs, that right there is a red flag. That's not random, that's a process breakdown somewhere in your workflow. And I'll take it a step further. Every non contractual write off should have a documented reason and a clear decision trail. Someone should be able to explain exactly why that money was written off and what was done before that decision was made. Because if you can't explain it, you can't fix it. And if you can't fix it, it's going to keep happening. And that is how revenue quietly walks out the door.
I imagine this is common in small amounts, but is there a dollar threshold where practices should really start paying attention to this? Like, at what point does this go from a few claims here and there to a real problem?
Great question. If your non contractual write offs are anything more than a handful of claims, it's a problem and it needs to be addressed. And just to be clear, when I say non contractual, I'm not talking about bundled or inclusive adjustments that you can't control. I'm talking about the preventable write offs, the ones we just discussed. Because if those keep happening, you're essentially working for free. Now, I want to make one thing clear to manage expectations. Your office or RCM vendor is not going to win every appeal, so you will see occasional write offs due to human error. That happens. But if you're seeing more than 5% of your claims being written off as non contractual adjustments, that is a major red flag.
So let's say that I am a practice or office administrator. I see, 8 to 12. How can I fix it?
At that point, you need to dig into it. What's causing it? Where's the breakdown happening? And what operational changes need to be made to fix it? Because this isn't just a billing issue, it's a workflow issue. Sometimes you'll have payer policies that classify certain procedures as experimental or non covered. And the reality is, there's no perfect threshold. If it were my money, I wouldn't wait until it becomes a big number to act on it. Even small patterns in non contractual write offs are worth paying attention to because they're usually early signs of a bigger issue.
That makes sense. So don't just look for one off claims, look at the actual pattern. All right. Well, that was exciting, depressing, all of this stuff. Let's flip over and let's look at those aging accounts receivable reports. What will these tell us?
Sure. Aging accounts receivable reports, aka your AR reports, are essentially a snapshot of how long money has been sitting out there that you're owed, but not yet collected. It's organized into buckets by age. Your 0 to 30 bucket should be your biggest. That's healthy money. It means the claims are moving through the system. 31 to 60 days should be smaller than your 0 to 30. These are claims that might need one follow up touch. Your 61 to 90 should be even smaller. And then this is where you start asking questions. Anything in the 90-day plus bucket is where the problems live.
Those are great data points. I feel like that should be a pyramid or a graph or something.
Here's a benchmark for everyone listening. If a meaningful portion of your AR is sitting in the 90-day plus bucket, that's a problem, unless there's a clear identified reason. Things like known payer issues that you're actively working through, or buckets like workers' comp, no fault, or out of network balances, those can behave differently and should be looked at completely separate. But outside of that, 90-day plus should always have an explanation. And if it doesn't, then that's where you need to start digging. And just to level set, while some payers can take 30 to 45 days to process a claim, days in AR overall performance metric in a well run operation, you should have a steady flow of claims paying at different stages, which is what keeps the number under control. And here's the part I want everyone to understand: AR doesn't build up because of one mistake, it builds up because of hundreds of small ones. A missed follow up here, a delay there, a pair change that wasn't caught. Over time, they just stack up. And that's when you start seeing real financial impact, and not a good way.
Okay, I have to be honest here. I don't think I've ever looked at an aging accounts receivable report. Is this because I'm an RVU-based surgeon? Can I assume that the hospital's business end CFO or at least our chair is looking at this? And if I did have an interest in getting more involved on this side of medicine in the future, what would I look for in this aging AR report?
That's a great question. And for our RVU based surgeons out there, these standard reports are still really important to understand, even if you're not living them on an everyday basis. The reality is, most surgeons, whether you're in a health system or a private practice, aren't really trained on how to read these. I take this is not something you're taught in medical school or residency, right?
That's a
No,
negative.
girlfriend, we're too busy learning where all the blood vessels are.
And not to hit them.
Yeah,
Exactly.
very true. But if you have access to these reports or you ask for them, here's what you need to focus on. First, look at the distribution across the buckets. You want to see a healthy pyramid, Most of your money should be in the 0 to 30 days bucket and should taper down from there. If the pyramid is inverted or flat, that's a red flag. Second, look at the trend month over month. Is your 90-day plus bucket growing? Even if the total AR looks stable, if the aging is shifting to the right, that's a warning sign. And third, look at which specific payers are driving the aging. This is something I can't stress enough. A single payer can skew your entire AR picture if claims aren't being worked. You might have one payer where claims are just sitting there untouched, and that one payer could be responsible for half your aged receivables.
So, if a surgeon or administrator looks at this report and sees a spike in that 90 plus day AR, what questions, without being aggressive, should they be asking their billing team?
Okay, here are the specific questions I recommend. First, which pair is driving the increase? You need to know if this is a broad problem or a pair specific problem. Second, is this a routing issue or a documentation issue? Those require very different solutions. Third, are these claims denied or are they just untouched? There's a big difference between a claim that was denied and is sitting in a queue and a claim that nobody has even looked at. Fourth, how many touches has each claim had? If a claim is 90 days old and it's only been touched once, that's a resource problem. Do we have enough staff to work this AR consistently? After asking yourself these questions, the real issue for a practice CEO or department chair becomes, does our team have the expertise, bandwidth, and infrastructure to resolve these efficiently? And if not, what is the financial impact to the practice or department in terms of missed revenue, delayed cash flow, increased denials, and administrative burden?
That last point really resonates because most of us assume that someone's keeping an eye on this. Like, we went into medicine to solve problems for our patients, not to spend time buried in reports and spreadsheets. Otherwise, I would have studied business. But somewhere along the way, I think a lot of us unintentionally placed our earning potential in other people's hands. And to be clear, this isn't about blame. I know that everyone, is doing everything they can to support the work that we do. But it's been a wake up call for me hearing all this stuff, and hopefully for other people listening, that we can't fully outsource our finances and our future outcome. Even those of us who are review based, not just a private practice problem, which I honestly thought that all this stuff was. Now is time to start thinking about this and understand what's going on, talk with the billing team, review these reports, and understand what the challenges are to our practices, even if they're huge, and try to stay engaged in these solutions being put in place to ensure it's being reimbursed appropriately.
I agree completely. Listen, when we run an audit for our practice, just to see if there's anything we can help with, we always find it's not that the people aren't working or trying their best to resolve these issues. It's that the team doesn't always have the right visibility or the right tools to know what to prioritize. They might be spending hours on low dollar claims while high dollar claims are just sitting there. Without the data to guide them, even a hardworking team can end up spinning their wheels.
The other thing that I think everyone listening needs to remember is, in my mind as a patient, when I go into a doctor's office, I want to know that the vast majority of the people sitting under that building are there working on healthcare and trying to ensure, the best outcome and care for the rest of us patients. I'm really hoping that not over 40% of that staff is trying to figure out all of the payer complexities and, calling insurance, companies back over and over again in these third-party clearinghouses. So I think for me, if I were to be in the business stance in practice, I would try to figure out how can I maximize every person under my roof's time on patients, and what do I need to do to make sure that we're getting paid for the work that my clinicians are doing, but not having to try to not only manage patient care, but also then business care. So, okay, we've got a couple of great reports under our belt, but you did mention some metrics before when we were talking about this and really fleshing out the concept. So, can you please walk us through charge lag and payment velocity?
Charge lag is the number of days between when a service is actually performed and when the charge is entered into the billing system. This is really the very first domino in your revenue cycle. If charges aren't entered promptly, everything downstream gets delayed. Your claim submission is delayed, your payment is delayed. Your follow up timeline is compressed. It's a cascade effect.
Oh, hooray.
Exactly. Best practice is 1 to 2 days from the data service to charge entry. Anything beyond 3 to 5 days, it's a problem. Typically, due to operative notes not being completed right away, or there's a coding backlog because the coders are documentation, which I do want to mention I see all the time. Every single day a charge lag adds to a day of your cash cycle. If your average charge lag is 7 days, you're starting the race a week behind before the claim even gets submitted. So, for surgeons out there, when your department or practice is on top of you to get your documentation submitted or your op note signed, this is really why.
Okay, so let me make sure I understand this. All I have to do as the surgeon is just get my notes into the coding system same day or within a day, and I can help reduce the charge lag.
Honestly, it's a shared responsibility. Charge lag is really the amount of time between when the procedure is performed and when the claim is ready to be billed out. So, yes, the surgeon has to complete and sign their documentation promptly, the operative note, procedure details, implants, all of it. Then, once that documentation is available, the coding team needs to review it, code it, and get the charge submitted quickly. If the surgeon finishes the note the same day, but the coding team has a 5 day backlog, you still have a charge lag. And on the flip side, if the coding team is ready to go, but the operative note sits unsigned for a week or two, same issue. That's why a lot of practices track charge lag by provider and by department because it helps identify where the bottleneck is actually happening.
By provider? That's interesting. Imagine that would generate some lively conversations at our private practice friends meetings.
It definitely can, but sometimes a little transparency is exactly what a practice needs to move the needle.
Agreed. Okay, so that's charge lag. Now let's talk about payment velocity. So, A, what is it? How is it different from days in AR? And how come I now have to be well versed in classical mathematics just to understand how surgeons get paid?
Well, luckily, it's not that difficult, especially for me and everyone here. Payment velocity measures how fast money actually comes in after a claim is submitted. It's the difference from days in AR because AR measures the total time from data service to payment. Payment velocity specifically isolates the time from when the claim goes out the door to when the check or process notification of the claim comes back. Velocity tells you whether your claims are flowing smoothly through the payer systems or getting stuck somewhere. And here's where knowing the velocity metric gets really useful. A sudden drop in payment velocity for a specific payer could signal a number of things. Maybe the payer changed a policy, maybe there's a system issue on their end. Think of payment velocity as like an early warning sign.
Can in practice track this by payer? Because that seems like it would be really telling to see which pairs are fast and which ones are slow.
Yes, and that's exactly how high performing practices and health systems use it. They track payment velocity by payer, by procedure, and even by location if they have multiple sites. The level of granularity is what turns raw data into actionable insight. You stop guessing and you start knowing. And when you see a payer whose velocity suddenly drops, you can intervene before it becomes a major AR problem.
I love it. That's a great way to enable a practice or health system to be really proactive versus reactive. All right, let's get to what everyone loves, which is a good dashboard, right? We've talked about adjustment reports, we've talked about AR aging, charge lag, all these great things, payment velocity. Let's zoom out, let's lift up a little bit for a minute. If a practice or a health system wants a single place where they can see the health of their rev cycle, what should be on this dashboard? And how often should they be looking at it?
Ugh, that's a great question. Here's what I consider the core KPIs that every practice or department should have in their revenue cycle dashboard. The three we discussed in the last podcast, which was clean claim rate, first pass resolution rate, denial categories, all broken down by payer and procedure. What you should also see on the dashboard is charge lag, days in AR, payment velocity, adjustment trends, contractual versus non contractual, month over month, top denial reasons by payer, and top procedures denied, along with why they were denied. Now, here's the hard truth most practices don't have dashboards that show all of this. Either the billing system can't produce the reports, or the team doesn't have the time or the expertise to build them. And even when dashboards do exist, they often are reviewed way too infrequently, or they're reviewed again without context, meaning someone looks at the numbers but doesn't really know what good looks like versus bad. Or they're reviewed without any action items attached. Or again, they're reviewed without accountability. Nobody owns the follow through. Remember, a dashboard only matters if someone is using it to make decisions. Otherwise, it's just another pretty spreadsheet.
So how often should we be actually looking at this then? Every month? Every week? Because I'm also thinking about how realistic this would be in a busy surgical practice.
Definitely monthly at minimum for a full revenue cycle review with the team. And by the team, I mean whoever is managing your billing operation, whether that's internal staff or an outside RCM vendor reporting back to leadership and your practice administrators. That monthly meeting should review the core KPIs, look for trends, identify problem areas, and assign action items. Now, certain operational metrics, especially denial trends or sudden shifts in cash flow, should be monitored more routinely, in my opinion, especially when you want to see these things throughout the month because those can snowball pretty quickly. And if nobody catches them early, it's going to be a bigger problem.
Okay, I apologize because it's not funny, but I'm literally scrolling back through my memory bank, thinking of all the times one of my surgeons has called me after a partnership meeting and they just sound deflated, exhausted, and they probably went over some of these KPIs and dashboards at that meeting. So, okay, I'm sorry. Once again, I know it's not funny. I'm like, that's why he sounded like that. Okay, so Dr. Campbell, to your question about how realistic is it for a busy surgical practice to review these reports, that's exactly what I was thinking. And that's such a heavy lift. And so, especially for surgeons and private practice, right? Because by and large, that shift that Lex was talking about from complete pure RVU, you work for it, you get paid for it, shifting in health system employed to more collections based, that's a lot to be accountable, especially with a super busy clinical workload. But if your livelihood depends on rev cycle running smoothly and the team being proactive, how do you even find the business manager or the administrator that knows how to compile all of these dashboards, that can read them? And I mean, I would hope that it doesn't come down to the surgeon, but I've been to a few meetings where it's mostly administrators and thinking about all of the things that they're in charge of doing, it just feels overwhelming even to me that on top of managing the practice, being a good steward for the patients, for the clinicians, seeing strategically in the market, 3, 5 years in advance, how in the world, do you have a level of engagement with the surgeons where they understand what's being done, but even just unpack it yourself as an administrator? So I think, Dr. Campbell, I'm so sorry. I believe you had another question.
Yes, I did. If the practice has none of this right now, like if you're not getting any regular reporting, there's no obvious dashboard, where do you even start?
Where do you even start? Great question. And I promise it's not that overwhelming. I would say I would start with three reports, just three. Your adjustment report, so you can see what you're writing off and why. Your AR aging, so you can see how long money is sitting out there. And probably your denial trends by payer, so you can see where claims are getting stuck and with which payer. If you start there, you could probably identify 80% of your revenue cycle issues if there are any at all. Once you get comfortable with those, then add more KPIs to the dashboard over time.
That feels pretty doable. 3 reports, just like how most surgeons usually have 3 codes that we use all the time.
Well, Lex, Abigail, thank you so much for your time. This was incredibly informative, and I hope our listeners out there aren't overwhelmed by this. I hope they're empowered. They've written a few things down, maybe. And, once again, Dr. Campbell, Lex, thanks for being here.
Happy to be
Thank
here.
you.
I'm learning so much.
Yes. And Marnie, thank you so much for having me. But if I could really quick, if I could just leave everyone with one thought, I want everyone out there to ask yourself this question. When was the last time someone on your team sat down with you and walked you through an adjustment report, your AR aging report, your denial trends? And I'm not talking just an emailed PDF or a spreadsheet that you're left to struggle through on your own, but actually explained what it means and what's being done about it. If you can't remember the last time that happened, or if it's never happened, then the question isn't, is your practice losing money? The question really is, how much money have you been losing and for how long?
That's a great question. And for those of you out there who answered it with a I don't think I have, please feel free to email Lex and ask her for a consultation or to go over some reports. You can find her at info@fellowhealthpartners.com. We will see you next time. This podcast is for educational and informational purposes only. The views and opinions expressed in this episode belong to the individual speakers and do not represent formal medical or billing advice. The Foundation for Physician Advancement and fellow health partners make no guarantees regarding outcomes, reimbursement, or financial performance, and we are not responsible for any decisions made based on the information discussed today.